last speaker, if I may, who doesn't again need introduction. This is last but not least. This is Sonya Babu-Narayan, who's a consultant colleague here and a full reader at Imperial College and deputy director of the British Heart Foundation. And she's undoubtedly the person who is taking cardiac MRI to a different level globally, not as a research, but as a clinical tool. She's done amazing work on tetralogy. And Sonya, wonderful to have you with us. You got 20 minutes. Thank you.
Thank you. I will just try and share my screen successfully. Just bear with me. It's a pleasure to talk to you all today about tetralogy of Fallot. These are actually very common patients in our adult congenital heart disease clinic, and the majority are very well, but I do worry about them. Any of you who look after a high volume center and patients very late after repair will know that these patients are not fine forever. And I want to put it to you today that it's not only a lesion-specific approach we need to think about, so thinking about tetralogy specifically and what are the risk factors, but also a patient-specific approach. Patients have a lifelong condition, as we know, for all congenital heart disease, and the majority will do really, really well. But predicting that patient that's real, who will die suddenly or have very premature heart failure, actually remains quite difficult. I'm absolutely not today speaking about the kind of heart failure where your left ventricular ejection fraction is 35%, your NYHA class is 2 or 3, and you have a high degree of symptoms. I think, or for patients who need secondary prevention with ICDs. I'm really speaking about those well patients that have various risk factors that we're not sure how to weight and we're not sure how to treat, and how do we identify these important points where left ventricular or right ventricular dysfunction might become permanent or the burden of arrhythmia become too dangerous. We've clearly learned a lot about pulmonary regurgitation in the last decades. We still may have a lot to learn, but we're better at optimally timing pulmonary valve implantation. We know a bit about how to use right ventricular volumes. We know a little bit now that if you go too early, that's also not good for the patient from recent data. And I won't be able to talk about that in as much detail today, because what I'm going to focus on is who needs more than assessment of their hemodynamics and restoration of pulmonary valve competence going forward for their healthcare. What I do know is that if we put an ICD in every tetralogy of Fallot patient, our patients will not thank us. Many, many patients with this condition really do not like having an ICD in situ. They complain of anxiety, they have poorer quality of life, the burden of inappropriate shock is quite high, 25 to 30% even in the current literature. If they have this at a younger age, they're signed up for multiple generator changes with potential for procedural complications and infective endocarditis. So clearly that is not the panacea. But where are we at the moment, and why is that the case? Why do we sometimes feel we're not saving that many lives with the patients we have chosen, and we're missing people who we haven't chosen? I guess to be fair, we should also remember that in cardiomyopathy, left ventricular ejection fraction 35% or below doesn't identify correctly all patients at risk, and they also have more to learn. Where are we in congenital heart disease if we don't just want to put a defibrillator in nearly everyone? Well, most people who are looking after patients with this condition will have heard of the Kerry score, a shorthand of describing this really landmark paper, which is already back in 2008. These risk factors were derived from retrospective analysis from multi-center data on people who submitted their ICD patient cohorts. A subgroup of them, 121, had primary prevention ICD, of whom 31% had an appropriate shock. And the kind of risk factors we're supposed to look at are if the patient had a prior palliative shunt. That makes sense. We know intuitively that this would fit with a later repair, perhaps a more severe form of tetralogy in the first place. QRS duration above 180 milliseconds. That's been very, very well documented in the earlier eras, being an important risk factor for ventricular arrhythmia. It makes sense that a large ventriculotomy incision, an incision directly into the RV myocardium, would be a risk factor. Non-sustained ventricular tachycardia, I know there are many papers that say that's not significant, so I'm never sure how to add that into my score, and whether a more recent Holter without any obviates one that did have one in the past. And as for left ventricular end diastolic pressure, it's very hard to know to want to put somebody forward for an invasive pressure measurement just on the basis of surveillance, although we can learn a lot and infer a lot from echocardiography as to whether our patient has restrictive LV filling. And what these data were about is predicting appropriate shock. We must remember that's not predicting death. The other prospective data that we do have is about programmed electrical stimulation. So irritating the heart, if you like, in the invasive catheter lab to see if you can induce monomorphic or polymorphic VT. And if you can, it's not as easy a story for the patient. What's really good news is if you can't induce VT, it seems to be a highly sensitive predictor of being free from bad events going forward or poor clinical outcomes. Even with these data, which are some of the few prospective data in congenital heart disease, and in a large data set, 250 patients or so, I find it difficult to know if my patient really fits in the data. A lot of these patients were symptomatic half, and many had at least moderate pulmonary regurgitation and might be the kind of patients in our population we may have already implanted pulmonary valves in. And so they may be slightly different. Clearly, for highly selected patients, programmed electrical stimulation may have a role. So let's go to the guidelines. Maybe that's going to help us know who might need an ICD or other kinds of therapy. So back in 2014, this is the guideline from Heart Rhythm. I'm going to briefly read it. It's a class 2A indication that ICD therapy is reasonable in selected tetralogy of Fallot patients with multiple risk factors, such as left ventricular systolic or diastolic dysfunction, non-sustained VT. Well, I wasn't sure about that, but that's interesting. QR restoration above 180. Extensive right ventricular scarring. Well, I didn't see prospective data on that already, so we'll come back to it. Or inducible sustained VT at an EP study. So obviously quite driven from this important paper on ICDs in 2008. Guidelines have turned out to be quite consistent. These are the AHA-ACC guidelines from 2018, and again, saying primary prevention ICD is for tetralogy of Fallot patients with multiple risk factors, and they're pretty much the same thing that we've just said for the Heart Rhythm guidelines. And again, we don't know how you weight these. How do I decide how much is extensive RV fibrosis, or how bad is the systolic LV function, or who exactly should have a programmed electrical stimulation? And most recently of all, we have September's ESC 2020 guidelines. A comment is clearly made that ICD implantation for primary prevention remains controversial, and so far no ideal risk stratification scheme has been developed. And to date, consistent with what I've showed you already and the other guidelines, we're saying the same things, which I guess are now becoming the new tradition. I'd like to examine those a bit further, because this is, of course, for people who are looking for advanced discussion. Quite a lot of time has passed since 2008. It's quite difficult to apply the Carey score prospectively, not least because 2 of the measurements are invasive, and we want to do repeated surveillance during the road of the road that our ACHD patient has to travel. And new risk factors have been described in big data or prospective data, including impaired exercise tolerance, sustained atrial arrhythmia. You just heard from Costas that atrial arrhythmia can be a precursor of more important or ventricular arrhythmia or other disease and dysfunction. And I'm going to show you about other data that have come through. So if we are going to predict heart failure and death on the road ahead as patients age, we also have to account for the fact so far that a lot of the studies are small, they have soft endpoints. Even registries and descriptive studies that are larger are often focused on single markers or modalities. If they're retrospective case studies, they often are using case matching, which could be flawed, rather than randomized controlled trials, which are very difficult in our specialty. And sometimes, but what we do know is what we have so far has been an inadequate non-invasive risk assessment. So where will we be in 2024, 2028, and 2030 when these guidelines come around again? Well, hopefully some of these new factors will be incorporated and we'll know how much to weight them. We knew previously that brain natriuretic peptide increases related to mortality in congenital heart disease, but now highly specifically, we can say that's true in tetralogy, that the values are different from controls, that it can be increased in asymptomatic patients, and there are cutoffs that help predict who might get sustained VT or who might die. We've known for a while too that peak VO2 and VEV-CO2 slope indicate mortality, can predict mortality in Tetralogy of Fallot. Giardini showed that with relatively extreme impairment of both, and that's also been shown again prospectively in at least 2 different studies, including from our group. But these are not yet in the current risk algorithms. We have the indicator multicenter study, which has more than 870 patients, nearly 900 patients, looking from multiple centers at hard endpoints, death or sustained VT of 30 seconds or more. And interestingly, the things that came out as predictive were an excessive right ventricular mass compared to volumes, so RV mass volume ratio being increased, history of having a sustained atrial arrhythmia, a theme in congenital heart disease. Atrial arrhythmia may reflect ventricular dysfunction and is certainly a risk factor for future mortality. And you can either put left ventricular ejection fraction or right ventricular ejection fraction into the model to predict death and sustained VT. This had only 28 outcomes of death, despite the effort of multiple centers and many years of investment, but has been proving to be a very, very important source of ongoing information for how we should treat tetralogy of Fallot patients. We've shown in our center that a simple linear measurement of the right ventricular outflow tract, which we didn't expect to be predictive, predicts first onset sustained VT or VF, so significant ventricular arrhythmia. None of these data that I'm showing you are predictive of just frequent ectopics or non-sustained VT. We're only going to be talking about hard endpoints today. We know from some cross-sectional data, so this is not prospective data, that if we look at late gadolinium CMR, which I'll come on to for those who are less familiar, but it's a way of inferring fibrosis in the heart or scar, that more extensive right ventricular late gadolinium enhancement, so seen in the dark black bars in this histogram to give you the idea, was associated with everything we know is bad. Increased age, late repair, already having presented with arrhythmia or syncope, having impaired exercise tolerance subjectively from your peak VO2, increased ANP, BNP, worse RV mechanics, actually worse LV mechanics, and also having LV fibrosis. And note that having a restrictive RV, which I'll also come back to, doesn't seem to be a good thing in terms of being in terms that it's related to extensive fibrosis. Perhaps that's not unexpected, since we consider a restrictive RV as stiff and potentially fibrotic. Importantly, in this cross-sectional data, we showed that having more extensive right ventricular late enhancement was associated with having presented with significant arrhythmia. So I counted in that atrial sustained arrhythmia or syncope. But these are cross-sectional data. They don't tell us in a prospective study whether this can predict mortality or ventricular arrhythmia in a sustained way. And yet this is one of the main reasons that extensive RV fibrosis is in our guidelines for who to decide about ICDs for. So where are we now, some years after Paul Carey's paper in 2008? We know sustained atrial arrhythmia is a risk factor, left ventricular dysfunction, systolic or diastolic, inducible VT at EP study, impaired indices at cardiopulmonary exercise testing, the increased size of the right ventricular outflow tract, decreased RV or LV ejection fraction measured by CMR, relatively increased RV mass, increased BNP. We also know fragmented QRS duration, which itself relates to RV, LGE or fibrosis, is a risk factor. And we think extensive RV fibrosis might be. But how do I add these up and how do I weight them in an individual patient? I find that really hard. So what we did at the Brompton is think how we would protocolize our service so that we could systematically address these questions. And we run an arrhythmia risk in adult congenital heart disease clinical pathway, which has been going on since about 2010. This doesn't mean that I or people who are running the pathway decide individually who needs a defibrillator or not, but it does facilitate coordinated care, organized investigations, including electrophysiology studies where they're indicated, and systematically thinking through all the measures and investigations in the same way for every patient so that we can document that and learn as we go. In practical terms, other adult congenital heart disease consultants will refer patients they perceive clinically as intermediate risk usually after they've had target hemodynamic lesions addressed, or we may be considering that at the same time. And typically in the past, these have been patients with a QRS restoration about 180, moderate RV dysfunction, say an MRI EF of 40%, or mild LV dysfunction, or patients having invasive EP for atrial arrhythmia, or people who have unexplained syncope, and we feel quite worried because it's a tetralogy of Fallot patient. There are some learnings already. So over the last years, we've seen 69 patients who, in a highly selected way, were then put forward for electrophysiology study to look for VT inducibility. This was clinically driven referral. The average age was about 40, and 43 of the 69 patients were male, and they had a relatively recognized and relatively aggressive stimulation protocol. The research was that preceding the electrophysiology study, we did 3D high-resolution late enhancement CMR. This is what that might look like. On the left are the kind of pictures you're probably used to from MRI. They look black and white is scar in these pictures. So if I point to some white areas, this is in the patient with less scar, the VSD patch site area, and this is the patient with a lot of scar, the VSD patch and septum area. These are single slices taken actually from a 3D block. And the advantage of the 3D block is we have factorially higher resolution, and for this time whole heart coverage, which means we don't miss any scar. These can be segmented and reconstructed and merged. And on the right-hand blue panel, you can see white scar, which is the distribution of the late enhancement, more mild end of the spectrum in the patient in the top row, and in patient B, really quite patchy and severe extent fibrosis. That hole is real. He has a residual ventricular septal defect in that region. When we have had the opportunity to cross-correlate these data with invasive electroanatomical mapping, we show that the low voltage areas on electroanatomical mapping, shown quite black in this picture over dark green for the fibrosis, match in region, and shown similarly on the right-hand patient who has more mild disease. What did we find? We found that sustained VT, inducible VT in the catheter lab seemed to be related to extensive right ventricular late enhancement. This paper is a proof of concept, really, although there are cutoffs on the graph I'm showing you, which show that everyone with 36 centimeter cubed or more RV late gadolinium enhancement had inducible VT, and everyone with very minimal late enhancement, 10 centimeter cubed or less, didn't have VT. We see there's an overlap between, in the patients in the middle, between those who are inducible and those who aren't for the values. So there's more work to do. What we sought to do was to try to predict a negative study, so somebody who's non-inducible, with the view that we could learn in the future how to avoid needless invasive procedures, but also how to help the interventionist who's proceeding to ablation of the VT know what to look for. In the end, it's a proxy endpoint. We really want to know about death, but this, I think, is a really important start. As we go forward, if we can learn with machine learning or learn about the characteristics of the scar in this middle group here, I suspect we'll be able to separate patients even further. But suffice to say, for now, very extensive late enhancement does seem to be a predictor of inducible VT, supporting the guidelines and the hypothesis that this is something that could be an arbiter for ICD decision-making also, or for facilitating successful VT ablation, which I'll come back to. Other groups often look for anatomical isthmuses proactively before patients have pulmonary valve replacement. This is a really important paper from Katja Zeppenfeld's group, defining isthmuses from invasive EP substrate mapping and ablation, and suggesting patients who have isthmus locations that would be caged or trapped after surgery could have them prophylactically treated in a highly personalized approach to reduce the possibility of those patients having VT. These left-hand colorful pictures are pictures from one of our own patients, where you see her 3D late enhancement in the top row, and where Dr. Ernst ablated between a region of scar superiorly near the pulmonary valve and one below near the tricuspid annulus to make the patient non-inducible at the end of the study. What if we can merge these two schools of thought and allow us to predict substrates and help the ablation therapy be successful. I do think there'll be some patients in whom we'll also say that ablation might be unsuccessful or not enough of a treatment if you have a very, very large degree of fibrosis like this patient, and there will be multiple sites of potential future VT. So, okay, but that's inducible VT, but not mortality. I'll try and go through this a little quickly for time, but we have looked at this very, very carefully over the last decades and now have 550 patients followed up in a prospective way with 3,800 years of patient follow-up. And this is looking at hard endpoints, sudden death or VT. For the first time in any congenital heart disease, we have now prospectively shown that indeed the guidelines can be supported. Extensive RV fibrosis, the red bar, predicts mortality. So this is a sole endpoint of mortality. There's no fudging. Well, that's what's new. What about all the other non-invasive markers? We don't want to have this single modality obsession and you just like MRI. Well, we've also looked at what else matters and thought about how you might weight it. So patients died of cardiovascular death primarily. It was not only sudden death, but heart failure. 2 patients had cancer deaths, and 8 things predicted death independently of everything else. The extent of your fibrosis in the right or left ventricle, right or left ventricular, ejection fraction impairment, increased BNP, peak VO2. These fit with the literature we had so far, sustained atrial arrhythmia, and increasing age. And we have worked out how we can weight these in a score to use to identify the patients at highest risk, the patients in the ballpark for whom we might want to think about primary prevention ICD or escalating heart failure therapy or other therapies. Of interest, non-sustained VT, increased QRS duration, and previous palliative shunt were not predictive of mortality in our study of 550 patients with this granular and deep phenotype data, nor was TAPSI and nor was a restrictive RV predictive of mortality. Cardiovascular mortality is from heart failure, not only ventricular arrhythmia, and when the paper comes out, you'll be able to see the nuanced differences between those who had clinical sustained VT, resuscitated VF, and sudden death, and those who succumbed from heart failure or arrhythmia mortality, but mainly the risk factors are actually very comparable. We remember there's ventricular-ventricular interaction in the tetralogy, like many conditions. There's been a lot of work over many years on restrictive right ventricular physiology, in the early days causing pediatric patients problems in the intensive care, and in the adolescents associated with a small heart, smaller X-ray, CTR, better VO2, smaller QRS duration. This is defined by an A wave throughout the respiratory cycle and pulse wave Doppler. Also associated with right atrial dilatation, and you see here this image of increased right atrial and right ventricular fibrosis in a highly restrictive RV patient. We know now that there's more than one phenotype. Some people have the smallish ventricle, which people assume may be a primary right ventricular fibrosis and restriction, and the secondary version where you have a big ventricle, perhaps after you have pulmonary regurgitation and the heart becomes full, and therefore there's forward flow in the pulmonary artery. But I just want to point out here too, there's a biventricular pathology. We see here biatrial dilatation, and the patients I find very difficult to treat are the ones with both RV and LV restriction and sick heart failure. Remember the RV fibrosis we showed and talked about. Well, there's also LV fibrosis in highly selected patients. We know there's interstitial fibrosis in the RV, very difficult to measure with MRI techniques. We'll talk about that in the imaging course. But Craig Broberg, who lectured to you earlier, has shown that if you measure interstitial fibrosis in the left ventricle and tetralogy, that is associated with atrial arrhythmia and death. So what lies ahead for 2030? I think we'll refine the ICD decisions to better avoid harm and save life. I think we'll be able to facilitate ablation selection and identify targets to make EP procedures easier using MRI. We need to integrate all these relevant but independent prognostic markers for personalized care. Machine learning on large data sets with records that include imaging and potentially multi-omics is the way forward. Our own data and data from the Mittal group and others which is highly preliminary, has shown that there are molecular markers of fibrosis and pathology in these patients that may be more individual. We need to add the burden of both focal and interstitial fibrosis, non-invasively measured, and perhaps fibrosis activity to our follow-up. And surely we need to learn from our heart failure colleagues. I look forward to Thomas Luscher's lecture today. There are 4 huge drug groups now with such good evidence in acquired heart disease: angiotensin receptor neprilysin inhibitors, beta blockers, MRAs, SLG2 inhibitors. We showed a small signal that the ACE inhibitors may have been actually useful in Tetralogy of Fallot, perhaps in this poorly designed study in retrospect. Maybe this is the time to do something collaborative and answer these questions so that we can have a patient-specific approach. Thank you.
Thanks a lot, Sonia. Wonderful talk. And so much to share and so much to do, isn't it, Sonia? This is just the beginning of the talk.
We have to keep our energy.
Yeah. We have some time for questions. And just to clarify something, the test live poll that we had was as to whether people do exclusively ACHD or not. And Lisa Freeman rightly from Norwich says that she does 80% ACHD and she does general cardiology. And some people do less ACHD and some people do very little ACHD. So everybody is truly welcome to this forum. And we need to work together collectively, which is the message that you get from all the speakers and from myself, to advance the field and provide for the patients. But Sonia, very briefly, I have a question for you. And looking at the future, I mean, this is remarkable work on cardiac MRI and fibrosis that you're doing with the team and us here. But how do you see the technology that we embrace here, including artificial intelligence? And we have sessions here, you know, Gerhard is part of our team and we'll hear more about it. But in terms of how do you see artificial intelligence and advances in technology helping us with taking this remarkable work into a broader audience and including fibrosis and the timing of it? Can you please comment?
So I think one thing is we need all the markers of risk rather than to be too siloed, but I will talk about fibrosis as well. I do imagine that we will start to work with thousands of patients in due course and be able to upload our data in an anonymized way so that we can use things that are biologically plausible or that we've already understood, but also in due course perhaps see what machine learning can truly tell us without our biases, things we, in some ways, if you look at the guidelines, they're quite biased to be consistent over a long period of time. Maybe being open-minded and not following dogma will allow us to see things we don't know about already. In terms of fibrosis MRI, I'm obviously aware that we really pushed that at the Brompton for congenital heart disease. That was something that's now already since 2001, but grown a lot. What I can say for people who come from other centers is I appreciate it. The picture you may receive in your report doesn't look like the things I've shown you, and even on the 2D side. But really, these sequences have got so much better, and a lot of even the 2-dimensional late GAD has become less operator dependent, and so it's actually easier for you to do it. I would never recommend it's done every visit. I would recommend that we do that at less than 5-year intervals, but then we do it properly with enough time in the magnet. The second thing alongside acquisition is interpretation and real world. I have a research group and we can spend hours making a pretty picture, and this isn't really going to be translated anytime soon. So one really attractive part of machine learning we're trying to work with is to now make that segmentation, which was done by hand, laboriously and with knowledge and expertise to exclude artifact from sternal wire or fat or things that are just not fibrosis by the human experience. But if we can make that very, very fast, like a few minutes, then that becomes much more ready for prime time, ready to use in everyday reports. As we do that, there's a second machine learning aspect that I find very interesting is there's so much data inside those pixels other than just how bright they look. There may be all sorts of things a mathematical modeler can tell me about the heterogeneity of the scar, the perimeter of the scar, the border zone of the scar, that might help us refine those patients that were sort of stuck in the middle with overlapping numbers if we just look at something as gross as extent. Going forward, our group, Andrew Reddington's group, other people have described, I think CHOP, data looking at genomics, and our own data too, looking at rRNA from tissue from the heart from tetralogy patients, raises lots of putative markers. These are the sorts of things we could do at scale if we would work together, collaborate, and biobank. And maybe it would be those data too that would feed into models, so that my dream is you sat in clinic, you type in a few things, the patient's results into the calculator, or it's automatically done for you, and it gives you a suggested annualized mortality risk or annualized ventricular arrhythmia risk. I imagine I'll go to my MRI scan with my boarding card to put into the slot. It'll tell me, it'll go through the metal detector. It'll tell me to proceed. I'll lie down on the table. I'll wrap the thing around me. 5 minutes later, it'll tell me to get up and go and take my printed report to the doctor. So I think things will change.
That's wonderful. You have this tool available to everybody because it's a global disease. This is terrific, Sonya. Colleagues, you'll have opportunity to talk to Dr. Babu-Narayan at networking sessions. I think we need to move on and allow for some time. We have different things and surprises for you on every single break. We have, I think, 25 minutes